Hello, good afternoon, or good morning, or good evening, depending where you are. Welcome to this webinar on deep dive on integration of ERNs into national health systems. My name is Concha Mayo. I'm going to be your technical host for today. And while we are waiting for everyone to come in, why don't you just write down your name and your city or your country in the chat box, so we get a better feeling of who's coming. As I said, my name is Concha Mayo. I'm based in Spain. And we have here Diana Marinello from Pisa, Italy. Welcome, Diana. We have Vicky McGrath from Ireland, Luis from Canada. So we have Katja as well from Schilhorn, Germany, Jürgen from Nuremberg in Germany. So we have such a nice and heterogeneous people joining us today. So welcome, everyone. I'm going to give you just a few recommendations. If you're not speaking, mute your microphones. Use a headset or earphones if you're going to speak, because it reduces the background noises. I also recommend you to add your name in the participants list, just in case you are logging with a different standard name. You can also raise your hand if you would like to speak, or write your comments in the Q&A box, and we will pass these questions to the speakers. So just be conscious of time, and I pass the word to Matt Johnson. Thank you very much all for coming.
Thanks, Concha. So today we've got two sessions. It's broken into two sessions. The first session I'm going to chair, and the second session Ines will chair. We're looking at the areas of best practice, which will illustrate how we can integrate the ERNs into the national healthcare system. So the first session, which I'm focusing on today, will be to look at why we should be accrediting our centres at the national level, the methodology around accreditation as a quality improvement system, and looking at the example of that in Sweden. The second session will be more looking at, once you've had those centres accredited, how connecting them together nationally under a network, and then seeing about creating a referral pathway through that network into the ERNs, and looking at how member states can support access for patients within their countries into the ERN system and utilise it. So we've got really great speakers today. We'll introduce them before each session. So just to set the scene really for the work which we're doing today. Up till now, the network, the ERNs were set up about 4 years ago. And as we progress with the second, the assessment of the second round of applications, we're moving to full coverage really of all member states in all ERNs. And as we do that, we then move the strategic focus really about making sure that each one of those member states benefits from these ERNs, and we can see about the integration of those ERNs and what role they play within the national healthcare system. So the board of member states highlighted 5 recommendations: one about national networks and accrediting centres of expertise, developing referral pathways, and then seeing how we can utilise the knowledge assets from ERNs like guidelines, care pathways, and seeing how we can implement them nationally. We'll cover those on the next webinar in September, October. EURORDIS did a piece of work around looking at what integration looked like a couple of years ago. My colleague Ines led that piece of work, and they were very much used by the board of member states to develop their statement on integration. And as you can see here, the 5 key recommendations which we'll be covering. It's a really good document to read. If anyone, it's available in all languages. We can make the link available to you after. So what we're doing in EURORDIS this year to support our patient community in their engagement activities at a national level is taking that statement on integration by the board of member states and trying to turn it into trying to break it down into what the methodologies behind that, each one of those recommendations is. What's the evidence base around that? What are the tools and techniques which can be employed, and to share best practice. And this series of webinars, it supports this toolkit. We can, if you have any other examples of best practice from your countries, please let us know, because we'd like to include it in the manual. So today, I've highlighted here that we're focusing on the selection of an accreditation of centres of expertise, looking at the referral pathways into the networks through the centres, and looking at national networking. So that will be the focus of today. The key questions really to ask in your country is, how can ERNs play a role in your healthcare system? Each member state's healthcare system is different, and therefore how they could utilize the ERNs will be different. So we need to ask that question at a national level. Each one of the key stakeholders, patient organisations, clinicians, managers of hospitals, and member state leads all played a role in the setting up of the ERNs. But now when we move to the integration agenda, each one of those stakeholders has an important role nationally within their own countries to implement the ERNs and connect them, and to stop them from being a parallel system. So today, we're going to focus the first session on the selection of an accreditation of centre of expertise. And I've got the pleasure of introducing Dr. Louise Clermont. She's an Executive Director of Health Standards Organisation, HSO, in Canada. They lead on accreditation internationally. I had the pleasure of working with Louise on the development of the assessment framework for the European Commission for the ERNs, and I'm continuing that work with Louise now, working with the WHO on development of a global network for rare diseases. So I'd like to hand over to Louise.
Need to unmute. Good morning, everybody. It's a pleasure to be here this morning, and thank you, Matt and the team, for inviting me. I guess we'll start with my slides. There we go. Perfect. Okay, we'll start just with the first one. Excellent. Everybody can hear me well, Matt? Concha, we're good? Okay. Just wanted to start by really thanking my team. This presentation today will be done by me and Elena. Elena will be on video, so we have a little 7-minute video to share with you to tell Elena's story. But I had a great team behind me to be able to do this, and so I just wanted to, I promised I would thank them officially during the beginning of the presentation. Next slide. So I'm speaking to you today from Canada. I'm in the smallest province of Canada today, a small island called Prince Edward Island. As Matt and a few know, it's my little heaven on earth. And today is what we call Canada Day. And usually it's a day of celebration. And I just wanted to acknowledge today that regrettably in Canada, we have, our Indigenous people have had to suffer and live some very difficult situations that have been lived by them through, policies of our government, by white settlers like myself. And so for us today, it's more of a day of reflection than celebrating our Canada Day because of this harm that we've, and the grief and suffering. So I just wanted to recognize that. Here in Prince Edward Island, I have the privilege to spend my summers on the land of the Mi'kmaq, which are Indigenous people, First Nations, and this is their land. And I think that's important for all of us to be aware of that. Next slide. So what I wanted to do with Elena today, and Elena will be on video, is to share with you the accreditation experience of one of the provinces in Canada, which is Quebec. And it's really about telling the story And as you hear my story, hopefully our objectives of this Quebec experience was to really change accreditation and its vision of what it is, and really bring in three key principles. So embedding the people-centered approach in everything we do, a shift to quality improvement principles versus quality assurance principles, finding that balance, and how to introduce new assessment methods in accreditation. This is a journey for us. It's the beginning. We started in 2018. We have a project, our accreditation with the province of Quebec is over 8 years, and actually 10. And so you'll see that this is really a learning journey for all of us. Next slide. So everybody talks about quality improvement, and I said, okay, try and find a good definition. Not easy to find, but the Health Foundation in April 2021 actually has a definition in their new document on quality improvement, and it really resonated with me. I'll read it out loud. The quality improvement is about giving the people closest to issues affecting care quality the time, permission, skills, and resources they need to solve them. It involves a systematic and coordinated approach to solving a problem using specific methods and tools with the aim of bringing about a measurable improvement. And so this very much resonates with our principles and how we've been introducing our accreditation program in the province. Next slide. So our standards that are developed by Health Standards Organization focus on criteria, what the ERNs call requirements, and they're really based on 8 quality dimensions. Depending on the requirement, we tag a requirement to a quality dimension. So the comprehensive program, one is population focused, work with my community to anticipate and meet our needs. Accessibility, give me timely and equitable services. Keep me safe. To be able to keep people safe, you obviously have to take care of those who take care of me. I think COVID and the pandemic has shown the importance of the workforce and well-being, not just on patients. Client-centered services, so partner with me and my family in my care. The importance of continuity, coordinate my care across the continuum. Is it appropriate, doing the right thing to the best results, the right time, and the efficiency, so making the best use of resources. So these are the quality dimensions that are used when we build our standards and our accreditation program. So Elena has become a friend as well. She's my partner in crime in trying to really bring in the importance of people-centered care in everything we do. And it's always a privilege to hear her voice, hear her story. Elena could probably talk for hours about her stories. Every time I have a new theme to present on, I'll go back to Elena and say, what's your experience? And because of her, like she says, her chronic use of the health system, she has quite a few experience to talk about. Some of them are good, and obviously there's some gaps as well. Next slide. So taking Elena's story, it's really those principles that have brought us to accredit differently in Quebec. So Quebec is one of the biggest provinces of Canada. What's unique to Quebec is the ministry covers both health and the social care system. So already here, there's signs of integration happening. It's a province of 7 million people. Most of the people live along what we call the St. Lawrence River. And so this is really like the urban strip, and then there's a lot of communities that are rural. The province is divided into 33 publicly funded health system organizations. And as you can see, there's a vast geographical area. And obviously, urban care is always different than rural care. So a lot of challenges for the Quebec population. And the way the ministry has set up their system is built on programs of care. So when we built the accreditation program for them, it was based on these programs of care, and I'll explain to that a little later on the next slide. So first thing we did with the Ministry of Health is we came together and made sure that we had common vision. So we built what we call our design principles. Again, number one, coming back to the people-centered care model, looking and assessing healthy and competent workforce. Universal health coverage is an important foundation in the province of Quebec to be able to offer care that's publicly funded. They had a very clear ask that we align the accrediting program with their strategic goals that were up until 2028. Accrediting and assessing safe, reliable, and quality care, introducing what we call the continuous quality improvement and not so much quality assurance. They wanted our accreditation program to be standardized, so to be able to apply the same standards across the 33 public health systems. So to be able to do that, they wanted our tools to be as standardized as possible. Next slide. So if we take Elena's experience and Elena's story, we've built the accrediting program exactly based on that. So as much upstream as downstream, looking at health prevention and promotion, knowing your population, awareness of information on disease incidence and prevalence, what are the screening programs. So a mix of population health and public health is assessed. Then we look at the services close to home, whether they be primary care, urgent care, and looking at coordinated referral systems. How do people travel along the trajectory? Access to highly specialized care. So be it just hospital care, but then very specialized care for rare disease. And those usually happen in our academic centers. Again, the more we get specialized, the more we have to look at an interdisciplinary approach and the importance of care transitions, because it's always a back and forth, right? It's never going just one way. And the importance of the reintegration into the community. So the recovery, Elena speaks of her self-management, how it's a full-time job to be, to manage her care. And all this comes back to the importance of integration. Next slide. And so this is how we're doing the accreditation in Quebec over a 5-year cycle, and the cycle will be repeated a second time. The initial work we did was looking at the organizational structure. So we assess on governments and leadership and public health. And as you see, as we go through the cycle where there's multiple touch points and peer reviewers are going in to assess, we're looking at programs of care. So it's really on the continuum of life, starting from youth, mental health and addictions. And the reason we did mental health and addictions at the beginning is we know the incidence and prevalence of mental health and addictions start early, between the years of 10 and 25 years old. And so we thought it was important to integrate the youth and mental health together. Then the 2020, 2021 is physical health, which is more about the acute care in hospitals, and then linking that with the programs related to primary care and social services. As we know, we don't live in hospitals. We go in for an acute, or whether it be planned or unplanned, but there's always that foundational care happening close to home. And then the last two programs really look at rehabilitation, whether it be physical disabilities, intellectual, autism, and spectrum disorder, very much coordinated as well with the education system. And lastly, the care of the elderly. And the last three that you see at the bottom, the four actually with virtual health, these are really on medication management, infection prevention and control, and are looking really at those safe, standardized practices that we're expecting to see across the organizations. So this is how it works. And so what's happening with the health systems is they're being assessed. There's always something going on. And the idea is it's stepwise, it's continuous, it's not all bunched up in one visit, but really over time. And there's continuity between the different programs as well. So how do the programs integrate horizontally as well as vertically? We're now, as you can see, in mid-2021, actually July 1st, we're obviously a little late in our physical health and primary care because of the pandemic. And so we'll be catching up on that in the 6 months to come. So we will be making our objectives on our timelines to end by 2023. The next slide. And so as we develop this program, it's all again about the people. I can't just emphasize how much people are important in this. You can have the best content in the world, but if you're not working with people, it's not going to work. And quality improvement is all about people. And so this is our ways of working and how we've been bold and courageous to really work in a collaborative way, hearing the voices of all. Elena is part of our strategic team on this. We do some active listening. We don't go in saying that we know everything. We try to innovate, but at the same time, learning from the past. So we don't want to reinvent the wheel. We really empower teams to speak up, to give us advice, to say, Louise, you're off your rockers. This is not going to work. We're going to have to find something different. And so we're very, very supportive of the empowerment of people. And it's actually the sum of all parts that make this such a positive journey for all. On the next slide. And so this is very quickly, we talked about content, and it just shows that continuity of, it's not a one-time deal. There's different activities happening all the time. And we've also got some survey instruments going on so that we get that qualitative response as well from the workforce, from the governing boards, and we also have a survey on patient experience. Next slide. So this is what our assessment manuals, we've got 6 of them. And as you can see, they're built based on the programs of care that we offer, that the Quebec Ministry of Health and Social Services offers. The next slide. And in each manual, they're built into chapters, and they're standardized across all manuals. The first chapter looks at service excellence, and this chapter is the same in every single manual that we've developed. And the idea there is for people to reflect on their delivery of care model based on what are the population needs, what are the competencies you need, and who are the people that you need to be able to offer those services, what type of decision support do you have for evidence-based practices, how are you measuring your outcomes, how are you doing, do you know what you're doing well, what you can improve on. And we push as well principles of integrated quality management and risk management. And then the subsequent chapters are really for care teams, depending on where they're working. So if you have, obviously, an emergency department, chapter 2 will look at the episode of care, what's happening in the emergency department, how the teams are working with patients, the type of care they're getting, the quality, the safety. And you'll see that every care service, care environment chapter has the same 3 safe and reliable care practices that we're looking all the time. We're always looking at the applicability of infection prevention and control practices. That is universal, irrespective of the type of care you're offering. You have to have good practices in place. Same thing for medication management. And so these are always the safety practices that we're assessing all the time in every clinical care environment. Next slide. And our methods. So there's a lot of content. There's a lot of activity going on. And so we had to introduce different methodologies to do our assessments. So one of the principles of quality improvement is what we call reflective practice, to ask yourself, well, how are you doing? You can have peer reviewers come in and say, this is great, this needs to be improved, but it's really important to do those self-reflective practices yourself. So we've introduced what's called self-assessment, and they're assessing exactly on the same criteria as the peer reviewers. And so there's a lot of transparency going on, nothing's hidden. We do some on-site assessments with the peer reviewers. We've introduced virtual assessment. That was not planned, but that happened with COVID. So there's ways now, as virtual care has increased, there's ways of being able to do some assessments virtually. Again, a learning curve. We're going to have to evaluate how that works. And a newest method we've introduced is called attestation. And this is where the organization itself has the accountability to sign off on requirements. They tell us, and this is the CEO or the governing board will sign off, a bit like when you do your income tax return, to attest to saying, yes, these activities are there. The attestation really looks at requirements related more to policies and documentation that are required for quality improvement or quality assurance at that stage. And so we're introducing this method to be able to really focus when peer reviewers go on site to really actually speak with people and not to spend their time reading documents. And as I mentioned earlier, we've also got the survey instruments where we're getting the lived experience, whether it be of patients, caregivers, families, as well as the workforce. The next slide. And so this is a bit of our story. It's been an amazing journey. We've had to work fast. We've had to work in a coordinated way. And again, coming back to Elena's story, this really inspired us to do differently. I do have to share with you that working with Matt and EURORDIS, when we built the ERN framework for assessment, was probably foundational to what we were able to do with the Quebec experience. And I can't emphasize the importance of integration. So very exciting to see what the member states have recommended for the journey on ERNs. It's very much like the Quebec experience. The journey always continues, it's never finished. The importance of evaluation to make sure that you share your lessons across and within the teams and improve upon that. And our next big focus in the next cycle will really be on outcomes. Our standards are very much structured and process-based. And when we hear Elena's experience and experiences of others, we now have to start thinking of accreditation and what's the value to those that we serve. And so how do we start introducing patient-reported experiences? And how do we talk about PROMs, reported outcomes? That will be over time, obviously. So demonstrate over time that you're improving. It will be the next step in our journey. So thanks for sharing, listening to me.
Thanks, Louise, for sharing your experiences in how you're developing an accreditation process in Canada and Quebec. As Louise mentioned about moving from standards which are focused on structure and process, actually accreditation can move to more looking at the outcomes of treatment and be accredited based on the performance of clinical performance of surgery teams, etc. So we'll save some questions. We'll have a panel discussion after the next presentation. So please put your questions in the chat and we'll come back to them when we do a panel session. But I've got the pleasure, thank you, Louise, and thank you to Elena for sharing her story. Moving to Per Heinrich from Sweden. He's the deputy head of unit for health and welfare, which is Socialresel. I can never say that right, I'm sure you would say, which they commission the highly specialized healthcare in Sweden. So it's a system which I think is fabulous because they look more at outcomes to accredit. But Per Heinrich will give an update on their approach.
Thank you, Matt. And could you please share my slides?
Just getting them up. A second. And yeah, there.
Thank you, and I think we can go to my first. short outline of my presentation. I will start with a short overview of the Swedish healthcare system, and then take you through our previous system for highly specialized care and the modification that has been done to that, and what we call now our new system for highly specialized care, which we're currently working with. And I will end by talk a bit about the ERNs in Sweden and integration of ERNs into the Swedish healthcare system. So if we please, next slide. The democratic system in Sweden is basically a 3-level system. And we have elections on all 3 levels. The national level, the regional level with counties, and the local levels with municipalities. And healthcare in Sweden is very decentralized. It's run, most of healthcare are run by the counties. We have 21 counties in Sweden. We are around 10 million inhabitants, and we are very unevenly distributed between those counties. Approximately 75% of all healthcare are being run by the counties, and that includes all hospital care, all primary care, psychiatry. Municipals also run healthcare, and that is nursing homes and could be special home care services. On the national level, we only have one system, and that is our national licensed services, what we're calling national highly specialized care. And if we go to the next slide. There also exists another sort of level in the healthcare system, and that is that the 21 counties, they collaborate in 6 different healthcare regions. And you see them on the colored map to the left. And those healthcare regions are also quite uneven in terms of size and number of inhabitants. All healthcare regions have 1 university hospital, apart from the Mid-Swede region, there we have 2 university hospitals. And university hospitals are, of course, very important for our highly specialized services. So please have these structures in the back of your mind when I continue the presentation. Go to the next slide. In 2007, a national law was introduced for highly specialized treatment, and the Swedish word for that system was called rikssjukvård. And in that system, the aim was to centralize the most advanced care to 1 or 2 hospitals in the country. And only hospitals that were given a permit are allowed to perform that specific care. And the system of how to define areas and make this decision was also introduced. And a short overview of that is that nominations of areas that could be of interest were introduced, and then the National Board of Health and Welfare made a decision to work with some of these areas. There was a work that was done by the agency, and a definition of that area was put forward. And that was a work that could take some time, it was also important to get some sort of agreement that this is a good area to work with. So we could spend 1 to 2 years before make a decision of a definition in that system. After that decision was made, there was possibility for hospitals to apply for a permit to perform that special service. And those applications were very comprehensive. It was important for the hospital to show that they were really good at that care, and we looked at medical results, we looked at the research, we got very thorough explanations and descriptions of how that service was given, persons involved, applications could be a few hundred pages. We engaged international experts to evaluate the research. We made on-site visits before putting forward a suggestion of decision. If we go to the next slide. So decisions were made in a specific decision body that was constituted of regional healthcare politicians from all 6 healthcare regions, and also representatives from a few governmental agencies. And that sort of review of application and decision process could also take 1 to 2 years. So we were actually spending 2 to 4 years on a specific healthcare area. In this system, we have time-limited permits, 5 then changed to 6 years. And I think the overall thinking behind this system was that competition will drive development of the healthcare. So after 5 years, we made a re-evaluation of an area, for example, heart transplants, and then in theory, other hospitals could apply for that. And if someone had performed badly, well, we could change to a new hospital. However, if you have not performed a specific care in 5 years, it's kind of hard to show that you are better than the ones who have done it. So in reality, this system caused quite a lot of work with reassessing an area and opening up all of the competition between hospitals that has not always been fruitful. If I'm not elaborating on that, it's been really hard competition here. And in no case we made a decision to change the permit of the hospital. So quite a lot of work, but no change in reality. And this system we had for around 10 years. And example of disease areas covered are lung, heart, liver transplants, advanced burn care, eye oncology, open heart surgery in children. In total, 15 areas were defined and permits were given. Then there was an assessment of this entire system was done, and it got a lot of criticism for being slow and inefficient, bureaucratic, and that this very competitive environment it fostered might not be the best way of developing healthcare, which led to that investigation led to a change in the national legislation. If we change slide also. So we now have what we call our new system for highly specialized care. And in Sweden, we have a slightly different name for it. It was introduced in 2018. And all the old permits have been transferred to this system. And the thinking behind a new system is that, well, highly specialized services should cover a larger proportion of the care given. In this, it's now been put forward that the definition is slightly changed. We could have disease areas with more patients, and that's being run on up to 5 hospitals in the country. So meaning that we will not have the healthcare given in all 6 healthcare regions. 5 or less is the definition of national in this system. The permits we are now working with, they don't have any time limits. You get the permit and then you have it. And our working process has changed quite a lot. The task for our agency is that we should go through all healthcare discipline in order to identify what care should be given on the national level. And we do that in collaboration with national healthcare experts. And we've set up specific working groups with medical experts. And then it's important to have this geographical diversity, people participating from all 6 healthcare regions. And we also have a patient representative in all of these working groups to have that perspective from the beginning. And their task is to make a definition in an area. So what should be given on a national level? And they basically come up with a definition. If we go to the next slide. And it's also been stated in our previous system, it was basically only surgery that has been centralized. It's now quite clear stated that not, of course, it can be surgery, but also diagnostic medical treatments and rehabilitation could be included. And we are now working with a less comprehensive application. Focus is, in our previous system, it was very much about assessing who is the best, or actually who has been the best, because we were looking only backwards. And now we have, within an area, we pre-specify certain criteria, and those have to be met. But then it's not a competition about who is the best above those limits. It's more important to look at the whole picture. What are the consequences for a certain hospital, a certain healthcare region, if they give a permit or if they are not giving a permit? And that these decisions should be forward-looking, not only focusing on the historical results as we previously did. And it's also important to look at all patients affected by this permit. Not only the patients of concern, maybe those one who will be given heart transplant, but also other patients affected by the shift in the healthcare system. It's of course a challenge to make that assessment, but it's important that the healthcare providers come up with their thinking. What will happen if we get this permit, and what will happen if we sort of lose this care from our region? And the overall decision should be based on a judgment, what is best for the entire country. And the decision board is a specific board now as well, and now it's only a political board with regional healthcare politicians from the different healthcare regions. So if we continue to the next slide. So far, since 2018, we have made decisions on 24 new disease areas that have been defined as national specialized healthcare. So far, permits, there still is this applications process and a lot of negotiations before decisions can be made. We have made the decisions of permits in 4 new areas. For example, advanced endometriosis surgery and pre-implantatoric genetic diagnostics. And there is a lot in our pipeline, but we had as as you all know, we have the pandemic has slowed down our work. An important thing of our new system is also the follow-up. As I said, we have now not time-limited permits anymore, but we do follow the medical results, and if you get a license as a healthcare provider, you are obliged to report yearly results. And we are developing indicators for what has to be reporting, and that is of course very much depending on the disease area. And we are publicly publishing them. And if we go to the next slide, we have developed a web system to publicly show this. Unfortunately, this is only available in Swedish, and these are screenshots from it. So there are different aspects of the care that we are interested in following up. It's of course referral pathways. If we look at the left here, it's the liver transplant permit, and then you see the Swedish map and the different counties, and the color coding here represent sort of the number of patients being referred to the specialized centers. There are 2 in Sweden for liver transplants, and then they are also adjusted for the differences in the number of inhabitants in different counties. And that gives us a picture of it. Are those services given equally? We would assume that the need for liver transplant is not geographically different. But there are really small numbers here, and we need to follow this for several years to get the sort of a true picture. So it's a bit early to draw conclusions. We just have data here for 2 years. We can look at other aspects. On the right-hand side, you see open heart surgery in children and adolescents, and just division between sex, between boys and girls. How does it look like? And if we go to the next slide, we also have some results, measurements, medical results. On the left-hand side, it's severe burn injuries, and that graph is showing the average time spent at the burn ward for patients referred there, and around 20 days. And you see a difference between different hospitals providing this care. Looks kind of similar for those 2 years. On the right-hand side, we have children receiving a cochlear implant, children born to deaf. And then there we have a sort of a figure for how accessible this treatment should be. If a child is being referred to this highly specialized center, it should be investigated within a certain time period, within 4 weeks after being referred. And this evaluation showed that, well, 83% of the children referred to the highly specialized center got that early initial examination within the pre-specified time frame. And so this is something we are using both to show results and to follow up. And it is possible for us to withdraw this accreditation if someone is not performing according to the standard set up. And this is how we work with the national highly specialized services. If we now continue to the ERNs, then we have to go back to the initial description of the Swedish healthcare systems, because ERNs are not part of the national health services. Almost all healthcare, as I said, is given on the county level. And so Sweden right now participate in 21 ERNs. We have 30 different expert centers. And in the ongoing call, we have 15 new applications being evaluated. And that includes the three ERNs not currently covered. So if they get accepted, we will have sort of full ERN coverage within Sweden. But then decision to apply for ERN membership, that lies on the regional university hospital level. That is nothing that we from the national level can steer or overrule. And we also lack a system for national quality evaluation for ERN applications. I know that a lot of countries do have that. In the Sweden system, we don't have the legal support for that. So the national endorsements we have been given from our agency basically mean that this application is in line with the current legislation. That is what we support. They are allowed to apply. So if we continue the last slide, it means that integration of ERNs is currently nothing we steer from the national agency. There is a lot of work ongoing in the rare disease community in Sweden, and all of these 6 healthcare regions, they have centers, expert centers for rare diseases that are not caregivers, but they are collaborating in a lot of areas regarding different aspects of rare diseases. The ERNs are not a formal part of those centers, but of course there exists a close collaboration in most areas. We do have examples when there is an overlap between the licensed national highly specialized care. Transplantation child, for example, there are some craniofacial in the groin ERN. But there are some other examples as well. But in most cases, the ERNs are not part of our national specialized services. And in our decentralized system, then collaboration is voluntary. Both ERN centers, referral centers, they have to find their way and develop referral pathways. And I'm really looking forward to hearing the Danish colleagues' experience on that. In Sweden, work is undergoing, but it's being driven then from collaboration starting in the county setting. There has been a national coordinator appointed, but still we have some work to do in Sweden before we see a sort of full integration of ERNs into the healthcare system, I would say. And with that, I think I'm finished. Well, thank you very much for giving the opportunity to present our way of working.
Thank you. It's really interesting. You know, my experience of the Swedish system was about really 5 years ago now, and I hold it with quite high esteem. And it's interesting to see that even your system is a system to be evolved, to develop. So accreditation of centres isn't a point in time, but as Louise had highlighted as well, it's more of a journey. It's always evolving and developing based on the different needs. So thank you very much for your presentation on that. We can open the floor to a Q&A session now. We've got about half an hour. Let me just, so if anyone would like to ask a question, they can raise their hand, and we can ask a question aloud, whether to Pierre Heinrich or to Louise Clement. And I'll just get the ball started. I can't find my questions. 1 second.
Hey, Matt, may I ask one question that was left in the chat a while ago? While Luis was showing the manuals, and Hugh is asking if there's a manual on autonomy of elderly with intellectual deficiency.
Yeah, that's a great question. So when we talk about transitions and the life journey, we can have very often, you know, youth with disabilities, and then they become adults, and then you get into that transition of disabilities from youth that become elderly, or a disability that's developed when you're older. So the services do exist. I think life expectancy is longer now, and it is a challenge to do it right. The Quebec, actually, I spoke with the Quebec government just last week, and they are building that philosophy of transitions based on needs of disabilities through the continuum of life. And so disability related to a cognitive disease such as dementia is very different than an intellectual disability from childhood. So the needs are very different, the lived experience is very different, and so this notion of individualized services is coming to being developed. And when we accredit, we're always looking at how are you approaching the needs of your population. And so we do ask that type of question, and to see how do you adapt to those needs. They're challenging, right? It's very challenging for health systems to address that, but that's the reality of today's world. If we're gonna think of health equity, universal health coverage, these important concepts that we're trying to promote in our healthcare systems, we're gonna have to look at that. So our manuals do cover that. I would say there's a lot of work to be done, but people are willing to. They're cognizant, I would say, that there is a gap, and that has to be improved.
Thank you, Luis. There is another question for you. That is, what type of aspects can be assessed through virtual peer review, as opposed to dimension that better assess on site?
That's a great question. That's something we had to ask ourselves actually very quickly with the pandemic. I would say a lot during our accrediting process with the peer reviewers, there are some activities that are happening through focus groups or dialogue with leaders that can actually be done virtually, right? Meeting with your governing body, meeting with leadership and discovering delivery of care models and your population needs. What's really important though is you can't go virtual when you have to observe the environment of care. I don't think we're there yet to walk around with cameras and stuff, and that the feel of coming into a care environment and that feeling that of the interactions between care teams and patients, the cleanliness of the environment, the safety procedures that are happening every day, the use of equipment. If you really want that lived experience, I don't think we can do that virtually. And so we will assess our virtual criteria because we tag them, what can be done virtually, what can be done on site. So if it's related to focus groups or documentation review, that is possible. We can go to virtual encounters like we do virtual care to get the patient experience and have a dialogue with them virtually instead of, you know, in their rooms or, but again, if you really want to have that full experience of the care being lived at the moment, which is also important, especially for safe and reliable care, that has to be done on site.
Thank you.
So I would like to ask Per Heinrich, in terms of, I've always been interested to see how you, because you're a very decentralized system. Other countries also have that approach, like Italy and Spain. But you also managed to enable that when you select centres, national centres, that patients who need that care do have a referral into that centre. It's not like a region would hold back referring them. That's not the case in Spain. It's not a mandated referral. So you managed to balance centralising stuff within a decentralised system. How did you manage to achieve that? Is it because you know, the budgets are all held locally, I presume?
Yes, they are, and they have to pay, of course, for services given at that national center. I think although the process going forward to the decisions have been a bump road sometimes, and a lot of, I mean, these are highly prestigious areas, and a lot of both professionals and clinics would like to perform them, and it's really hard to sort of to lose them. But still, once that decision has been made, they have been accepted. They have got general acceptance. Most people agree that in the long time we will benefit from centralizing those services in terms of medical quality, in terms of research possibilities. And it is regulated by law. The other hospitals are not allowed to do that. If they do that, they are breaking the Swedish healthcare law, and there is a different authority who are looking into adherence to laws and regulations. So they are following up on that. That is also, of course, part of it. Of course, it is sort of, for a specific patient, there could be, it's a gray zone to make that medical judgment whether you should go to that national service or not. But in general, our experience is that we have quite good adherence to those decisions. Of course, a transition period, but once done, you get acceptance. And then we also, as part of their permits, it's very important that the clinics, centers giving those specialized treatment, that they work actively with referral hospitals, both in terms of knowledge sharing, how are we doing, also of course international benchmarking in terms of medical results, but also around specific patients. Usually the patients will go back to their region, and the care needs to continue to be good, and they need to have a dialogue. And yeah, so they have as part of their task also to educate in that disease area other hospitals, because if you're not longer doing it, you will naturally not be following the latest research and so on. So they have an education task as well as in part of their permit.
Pierre, Matt, do I have time for one follow-up question to Pierre?
Yeah, of course.
Because I'm Spanish, I'm really interested to listen to this. Have you had, in Spain, really it all goes back to budget. So hospitals, regional hospitals sometimes really don't have the budget to pay for that kind of service, so they just retain the patient and they don't refer it. Do you have any special, apart from having a legal mandate, which is clear, so they need to do it, it's not optional, do you have any kind of special budget line that you earmark and you protect to make sure that the regional hospitals have enough budget to refer their patients and pay for those services? How do you make sure that there are no tensions there in terms of paying for those referrals?
No, we do not have specific earmarked money as of today, but that is very much an ongoing discussion. Since the centers said, given the highly specialized care, we want them to be active in research. They should educate other sites in Sweden. There is quite a large undertaking, and that of course costs. But as of today, they do not get sort of extra funding from the government. And if, as I said, our understanding today is that it is working, but part of the follow-up system I showed you, where we really would like to look at referral, I showed you the graph for liver transplants, is that what we know, when I said it's good adherence, we know that those specific services are not giving elsewhere. Liver transplants are not being performed in hospitals not having those permits. But whether all patients who actually would need a liver transplant are getting referred, we don't know.
That's the question.
Exactly, and that is why we are following now very clearly this. Given the low number of patients in most of these disease areas, it will take us a few years, maybe 5 years, before we can get this picture. And so I'll come back in a few years if people are being withheld. I mean, it could be money, it could be lack of knowledge, and so on. Also, we don't know really.
But that's good that you're monitoring. Good, thank you.
There is another question in the chat for Johan. Sorry, for Pierre, from Johan Hochreiter. And he's saying distributing different rare disease medical services to specific locations always makes some conflicts of interest arise. How do you overcome that? What role play national medical societies, any payers in the healthcare systems?
I think there are certainly a lot of both local and regional interests, and I think the system is sort of trying to be constructed in a balanced way. That when we start our expert groups, we are balancing them geographically and also in terms of course, expert knowledge, and that in the end, the decision body consists of accountable politicians from all parts of Sweden, and so it's very much up to them to make a balanced decision on who should get the permits. We sort of in our work assure that the quality is good enough, but then there is this final decision on that also could consider other aspects. So that's how we're trying to cope with it, and also that we are being transparent. The definitions we take forward that we've sent them up for a very broad review, so that both professional organizations, healthcare providers, patients organization can provide input before we are making decision on a certain definition. So that's another thing. We're trying to be really transparent, and then in our work have balanced groups. And I guess it will take us a few years before we can also evaluate if that's fully successful. I mean, it's tricky to balance all interests.
Matt, can I ask a question?
Yeah.
I always have questions to ask.
Always.
Per Henrik, I was wondering, between your highly specialized hospitals, do they have an obligation to speak with each other? Because when I'm thinking of rare diseases and the complexity, Elena's story, she tells me all the time, you know, her pneumologist, her transplant surgeon, her nephrologist, her psychiatrist. Is there any way that these highly specialized care are connecting themselves together and learning from each other?
Within a specific disease area, I would say.
It doesn't have to be specific, like just, you know, it could be kidney and liver, because they all get connected at some point.
Yeah, they are. It's hard to answer. In terms of how we steer with these national centers, then it's more within that disease area. You have to have collaboration. Whereas between disease areas, we have not. And then if we go to a slightly different structure with rare diseases, well, yes, there are a lot of specialists collaborating in those areas, but that is not regulated. That is voluntary.
Okay.
And of course, some areas are working better than others.
Mm-hmm. Mm-hmm. Thanks.
So I had a question, really. Just Louisa presented about the importance of patient experience, or the lived experience, and having that as part of the focus of assessment or accreditation. And I wondered, in Sweden, how you is it that you just benchmark on medical outcomes, or do you have the assessment, a part of the assessment where you look at patient experience to give a qualitative analysis of whether care is good or not?
Right now, we are just following up that they do collect patient experiences. We have the ambition to evolve this system also to include PROMs and PREMs. It's kind of hard to do, actually. So we haven't really figured out the best way of doing that, but our ambition is certainly to add that perspective as well. But to be honest, right now, no, it's important. We're just asking the question if they do collect, and they should collect those kind of experiences.
Henrik, we have another question in the chat for you. It says, how are ERNs discussed in Sweden? Is it mainly among the healthcare professionals, or are the politicians also focusing on the ERN systems?
They are mainly focusing on our nationalized specialized services. To be honest, not so much on the ERN system. We are working through this decision board. They have important roles home in the regions. We update regularly on what's happening within the ERN system and what we are discussing in the board of member states, but they have not sort of an obligation towards the ERN system. So it's for information.
Thank you. We have another one. Claudia is asking, so does this mean with a multidisciplinary disease, you have to travel between centers all over the country as a patient?
It could be, but in most cases, I would say not. We are now referring to these in every region. We have those expert sort of centers for rare diseases, and they really are collaborating with sharing knowledge and with the aim to not having to make patients travel all over the country. But I mean, it's a balance. Sometimes you do have to travel for a certain investigation or a certain procedure. Most of the rare diseases are, of course, lifelong. The aim is to provide as much as possible of that care close to the patient. Mm-hmm. And I guess that balance we do have to work with, I think. That goes for patients within the ERNs system as well. I mean, we would like to share the knowledge. Sometimes patients also have to travel.
Thank you.
I just wanted to, I've got a couple of questions for you, Louise, but I just want to finish off in terms of the Swedish experience, as it were. It's exciting that you're broadening the scope of your highly specialised from intervention to diagnostic and management as well. That feels like a very positive step. Is there a tension, or how do you balance providing sort of equitable participation from regions versus having a critical mass of patients to develop the expertise and safe and sustainable services? How do you make that call? And is it you always try and get 5 centres to cover the regions, or does your system also allow, actually, let's say for auditory brainstem implantation, actually we want 1 person to be doing that, and that should be at the Karolinska, because you need to be competent, otherwise it'll take you 10 years to figure out whether your centres are performing or not?
Yes, no, we that is very much a judgment for those expert groups making the definition. We don't have a pre-specified number that you should make, for example, 50 interventions or 30 certain surgical procedure per surgeon. But so the balance is to have as much centralization as sort of required to get the benefit from that, but not losing on the other side. And that means that different areas, we have different numbers of patients per center. An area we've just made a decision on the definition is the primary rehabilitation after spinal cord injuries, currently very decentralized in Sweden, and everyone, especially the patient organizations, are really promoting centralization. And then we have made a decision that it should be on 4 centers in Sweden to provide that quite prolonged period of initial rehabilitation, and a lot of sort of expert knowledge needed to go in there. And so, but basically it's based on the judgment of that expert group, and there we also have a patient representative part of it, and then we have this broad circulation of our definitions before making decisions to get other aspects as well.
Thank you. So Louise, you had so in Sweden there was a presentation, including the presentation was similar types of approach in terms of methods for assessment, like on-site visits, etc. You had quite a few up there. Is there one which is the best, or should we always do self-assessment, or is it important? Is it better to eyeball the services directly and have on-site visit? What's your experience in terms of the best approach?
I think it's a hybrid model. That's a typical answer, but The importance of, as we go to quality improvement, the self-assessment for me, and my past experience with stroke, comprehensive stroke care in the province of Quebec, is really about the reflective practice you ask the care teams to do. They're the problem solvers. They're the people that live the experience, and those care teams are inclusive of patients as well. Don't come in a little meeting together without patients. That's not going to work. But if you bring in the patients and you have that dialogue when you self-assess, how are we doing? It actually is recognition of allowing people, like the quality improvement definition of the Health Foundation, locally adapted problem-solving approach. But you do need the leadership support to be able to do that, right? It's very frustrating for teams to self-assess, recognize gaps, need resources, need changes, and then nobody supports them. That's frustrating. Clinicians, doctors, we hate that. We do it. And then after that, nothing happens. And then we never do it again because we say we never got what we needed. The attestation part is new. This is a new method for us. I do believe it brings accountability to leadership in organizations by doing that. And again, peer reviewers shouldn't be spending their time reading documents and policies. Peer reviewers need to pick up the experience of care on site. And so I really do think it's going to be more of a hybrid model of how you do that. Personally, I think virtual can be the encounters, individual encounters with people and express their experiences as well. But again, the virtual will not allow you to assess that feel you will get when you go on site. I mean, nothing, you know, when you've done a lot of I've had the opportunity to survey in a number of areas across the world. It's universal. You just know when you get onto a care unit, whether it be ambulatory, inpatient, wherever, diagnostic, it doesn't matter where the care environment is. You know, when you come in, you get that feel that this is good care, it's people-centered care, just the nonverbal of the teams. It could be the oldest building in the world, but if you get that feel of the people that are caring, compassionate, they do good care.
I'm just aware that the framework which was developed for the first and second call is being evaluated at the moment and updated under the Amicus consortium, and I was trying to figure out how to free up the bureaucracy of that system based on the legislation. I think the attestation model in terms of healthcare providers management saying, well, we sign this off, that gives accountability within the hospital, could then free up the application process and assessment into the ERNs to be more based on a qualitative assessment and reflective practice. I'm learning as I go, as ever. And I think with the Swedish system, I love the fact that, you know, outcomes are, you know, made public, reported annually, and that follow-up, that visibility. Your system in Canada, which you developed, is sort of more in its infancy, as it were, and you were saying you will be moving to more of a outcome-based system eventually. What's the steps in between, you know, an accreditation system and a new one based on standards, developing into one based on outcomes? What are the steps needed to mature?
It's a great question. I'll just come back on the accreditation. In Quebec, by law, one, they need to be accredited by law, and two, the reports that we provide every time we accredit, we do visits, are public. So everybody gets to see them. Now you have to find them. They're not easy to find, but they are public by law. So there's transparency there. Related to outcomes, here Hendrik said two things. They're written in an outcome-focused way. So demonstrate the evidence of improvement. So there's a lot of work that needs to be done on our standards writing about accountability, the action, and demonstrating evidence over action. And I completely agree with the prems and the proms. It's hard to do. It's very hard to do. it's moving away from what we call performance indicators that are set up related, like Ines says, to the budget and stuff. And it's really talking about indicators that are meaningful to the population. So it's a very different mind frame, and how you're going to collect that is we will have to invest in that to be able to do it well. Small steps for me, I think very standardized patient experience surveys, irrespective of the type of care they get, can already start to get some information about that, and brings back that reflective practice locally to say, they felt very anxious. Well, just having that experience of feeling anxious when you come in a clinical encounter, how can you, irrespective of the diagnosis, you can change that in your competencies and your skills and behaviors and attitudes, that culture change. But it will be challenging. If you have to, it's small steps, very small steps, and starting with what's important to patients to express their experiences and outcomes about. And I've found it fascinating that irrespective of the diagnosis, patients are asking the same thing.
I'm conscious of time. Concha, what is it?
Yeah, I was going to highlight that, and also mention that there is another question, but maybe we can respond that after the webinar.
Okay, so I'll just quickly sum up and then we can have a break. First of all, I'd like to thank Louise and Pierre Heinrich for your contributions, and you're sharing your experiences today. It's great to be able to see two different accreditation systems and see there's some commonalities around that, around how to define a service before you accredit. Patients being involved in that definition part of the process, what should be included, feels very important. That the subject of an assessment being the focus of the looking at patient experience seems also very important, because it sounds like it makes it more relevant to the clinicians to take part rather than a hurdle to be jumped in time. I love the fact that there's a role and responsibilities in terms of the permits in Sweden, not just to sort of, we're the best and we're now the lead centre, but a responsibility to work with referral hospitals in terms of education. So we don't create islands of expertise, but they connect and are integrated within a bigger system to support referrals and shared care arrangements in terms of follow-up. And it feels like transparency seems the most important thing really to this. Make it transparent about how we select centres, about the visibility of their performance as well, and that becomes a bit more of a reflective process in terms of practice. So I think we've 1 minute over, so I wanted to say thank you again for both of your contributions today. We're going to have about a 10-minute break. We'll come back at 3:45 sort of Central European time in about 10-12 minutes. And then we'll move over and we'll cover the second part of the session. So thank you for now, and look forward to continuing this in after a break.
Welcome.
Are the 10 minutes over, Concha, or not? 1 minute left.
1 minute left.
We'll give people 1 minute. Okay, so let me get started with the second part of this session. So we're now going into referral pathways more specifically, and national networks, national rare disease networks. The next slide, please, Matt. So can you do the whole thing so that we can see the, yeah. So on regarding referral pathways, and without going into a lot of detail right now, I just want to highlight to you that when we talk about referral pathways, these are the rules and the process, if you want, that is in place in a health system to organize the transfer of a patient or the transfer of a case from one level of care to another. So from primary care to secondary care, from secondary care to tertiary care, etc. And also eventually from the national health system into the ERNs. To cover this topic, we have invited today two Danish speakers. I'm really grateful to have them here because this is really something that is not in place as of today in any member state, the referral pathway into the ERNs. So how the doctors at national level can request a secondary opinion from the ERNs experts and use that resource is hasn't been formalized as a process today in any member states. They're starting to think about how to do it. And our two speakers have kindly agreed to join us and be here today with us to share some of their thoughts around this. I think it's very important also that we are aware that even though there is not a formal referral pathway, of course, some cases are being referred already to the ERNs, and the expert panels are working. So there is some activity going on, but if we want to have this at scale, we need some kind of formalization. So our two speakers are Per Johansen, who is the medical officer at the Rigs Hospital in Copenhagen. So that's a university hospital in Copenhagen, one of the leading tertiary hospitals in Denmark. And our second Danish speaker today is Søren Niemark, who is the board of member state representative for Denmark. And he's also specialist advisor at the Danish Health Authority. So both of them will be talking about referral pathways. And the second aspect that we're going to cover in this part of the webinar relates to national networks. And I think that you've heard Matt and me a zillion times now talking about how important it is to have a good and strong national networks, rare disease national networks, clinical networks, to integrate the ERNs into the national health system, how important, what an important role they could play to make that integration a reality. And we have invited today Professor Helen Dolphus, who is the ERNI coordinator, to share with us the 10 years experience of the Filière de Santé Maladie Rare in France, the lessons that they've learned, what are the success factors, because it's not only won't only be useful for national networking if you want, but what Professor Dolphus will share with us might also be relevant for the ERNs themselves that are in the end also clinical networks. So without any further ado, I'll give the floor now to Per Johansen. Per, I'm going to share your slides. So bear with me a little bit. Share screen. Let's see. Let me know what you see. Matt, let me know if that's okay or not, if it's okay or not. Is it okay? Okay.
I think it's fine. Thank you very much for having the opportunity to be here. It's really a pleasure. and I want to say greetings from a gray and cloudy Copenhagen, but I hope we'll get a good summer anyhow within the next week or something like that. I'm going to talk about how we have an informal referral system in connection with ERNs in Denmark, and our healthcare system is, not surprisingly, quite similar to the system of our good neighbors in Sweden. I would like to give you a short presentation about my hospital, because then you know from which point of view am I looking at the situation. Why do we think ERNs are important for us? Which memberships do we have and which do we hope to get? A very short bit about the Danish healthcare system, and then how we're handling the referral pathways for rare diseases through to a hospital, and then from the hospital through to an ERN. And then I would like to discuss the need for a national collaboration in Denmark if we should handle and use the ERN system in a good way. Could I have the next slide, please? Rigshospitalet is a tertiary university hospital in Copenhagen. We are providing specialized treatments for, in some cases, for all of Denmark, and in many cases for the eastern part of Denmark, and also for Greenland and the Faroe Islands. We have all specialties at our hospital except dermatology. It's a relatively big hospital with 10,000 full-time positions. And of course, we have a strong focus on research, 150 professors, 340 PhDs, and so on. And when I mention research, it's because I think that if you are going to participate and contribute in a good way in an ERN, you have to be very research active. And then we have permit for one of the 2 Danish centers for rare diseases at our hospital. The next, please. We think ERNs are important because, first of all, it gives us an opportunity to provide even better care for our very rare and complex patients, our own patients. Of course, it also gives us an opportunity to help other patients, which we also like to do. And the second important issue for us is that it strengthened our network with the leading hospitals in Europe. It makes it possible for us to contribute to the development of new clinical guidelines. It helps us in a very expert way to participate in the promotion of clinical quality and patient safety. And of course, we also consider the ERNs to be important for our research. And we think that being part of an ERN might become important for being able to receive EU research grants. We don't know that for certain, but we think that's the way it's going to go. The next slide, please. We are full members of 10 ERNs, and in that way we are the hospital in Denmark which are a full member of most ERNs. But we started out a bit careful because we didn't really know when the ERN were introduced, how was this going to go? What would it involve? How much work would it be? What would we gain by being members of ERNs? But we have been convinced that this is important, and we want to be much more active in the ERN work. And the next slide, please. This is just to show the number of full memberships we have asked for. We have received associated memberships for these ERNs, but now we're going for full memberships, and the ones that are marked by the yellow color are ERNs where we're still actively applying for a full membership. And as it's stated, we had, please go one back. We had an audit last month from the Genturis ERN, and that was a very good and also interesting experience, because it was an audit solely based on iPads and video equipment and so on, but actually it worked quite well and we were very happy with the results. So it was a good experience. And the next, please. The next slide, please. We're a small country. We only have 6 million inhabitants. We have a public healthcare system with 21 acute hospitals. Some of those are university hospitals, and then one tertiary hospital, which is Rigshospitalet. The private sector is not important in the hospital sector in Denmark. We have very few, and they are very small, and they are not involved in rare diseases. The GPs belong to the private sector, of course, but as almost all their salaries come from the public sector, they're very much integrated into our hospital system or our healthcare system. We have 5 regions, each with their own university hospital and acute hospitals. And then we have a system which is very, very close to the system described by Per Henrik previously from Sweden. We have a strong national board of health that are able to give permit to the different hospitals in regard of which which specialized functions can be performed. And we are looking at 2 different levels of specialized functions, those that can take place 1, 2, 3 places in each region. That's the regional specialized functions, and then the highly specialized functions, which can be taking place at 1 to 3 places in the country. Next, please. I've tried to describe the normal pathway for rare diseases through to a hospital. You start by contacting your own general practitioner, and then you get referred to a hospital. And you can, depending on what your GP think is the problem, you can be referred to, she can refer you to a local acute hospital, or she can refer you to a university hospital. Then the hospital can refer the patient when they know more about what could be the problem. Then the local hospital can refer the patient to a university hospital that have the permit for what the disease or the problem which this is likely to be. So you are referred from your local hospital or from a university hospital, if it's a very highly specialized function, to the hospital in Denmark who have one of the hospitals in Denmark who have the permit for this situation. And it can easily be found in our special plan. Next slide, please. How do we refer through to an ERN? I think most importantly, the doctors need to be aware of the ERN system. And I think that's especially important for the highly specialized departments, because the patients will be referred to the most specialized departments in Denmark before it will be relevant to consider referral to an ERN. So it's very important that our doctors at the highly specialized hospitals in Denmark are aware of the ERN system. A lot of them are aware of it, but so far, I think the ERN system is not common knowledge in the Danish hospital system. And when you have a patient, it also has to be easy to find the relevant ERN and the contact informations. Usually, I think that if a Danish child or Danish patient is going to be referred to an ERN, it will be from a university hospital having this highly specialized function or permit for this highly specialized function. And then you can refer to an ERN. You can go do it directly, or you can do it via a Danish hospital, which is an associated or full member of the ERN. Personally, I think that the best way to do it in Denmark is that it is a department that are a full member of this ERN, because it makes it easier to participate more actively in the advices given by the ERN and being a more active member of the professional environment in the ERN. So I think that's the way we're going to go, but I'm not quite sure yet. Next, please. The ERNs are not integrated in the Danish specialty plan per se. It's very much like Per Henrik told about in Sweden. It's an add-on system that are available to the experts that have the patient and can say, well, here it is so difficult, so rare, so complex, that it would be nice to get an expert advice on the very highest European level. I think it might also be possible that some patients would like to use the ERNs as a kind of second opinion, which can be discussed with the patient. And in Denmark, we can of course not refer a patient to an ERN without having talked very thoroughly with the patient and having had informed consent before we can ask for an advice under an ERN. Next slide, please. I think we need a national collaboration in Denmark, and I think it's necessary, because if we will only, because we're a little country, be able to have one hospital as a full member in most of the ERNs. And these ERNs will of course be divided, or these full memberships will be divided to different hospitals in Denmark. And I think we have a system so that the highly specialized departments in all our hospitals are collaborating with the department which are a full member of the ERN in order to refer patients to this department or refer the problem to these departments, and also to get feedback from the ERN system and to be actively involved in the work that's going on in the ERN system. As I've stated at the bottom of the slide, I think it's a problem that the ERN system is, at least in my opinion, bureaucratic, and our national legislation is a bit complex. There's a lot of things which, when we want to collaborate with ERNs, where it is not meaningful that every different ERN are finding their way through how to participate in video conferences, how to upload patient data and so on, what's in how can we do it with the Danish legislation. So an exchange of experiences will reduce the workload, and that's one of the other important areas for a national collaboration. And the next slide, please. We have not started this national coordination yet. We have talked about it, the biggest university hospitals in Denmark, and we have agreed that we will make this coordination, but we are waiting for the application process to be finished. We applied for associated and later for full memberships of the ERNs back in 2019. We have not yet received any answers, so we do not know which hospitals will be full members of which ERNs. And we think that it won't be meaningful to design or to make a Danish ERN network before we know how will these full memberships be distributed. So we are very much looking forward to receiving the answers for our applications. And the next slide. And that's just if there's any questions now. I'm sorry I didn't use all 25 minutes. I hope it's okay. Thank you.
Thank you, Per. Yeah, it's more than fine, than okay, I'd say. So I'm going to give the floor now to Søren. Sorry, did I? Okay. Do you want me to share my screen or?
Yes, please. Yes,
yeah?
please.
Okay. So
And just to be warned, I have a sick child, so if there's any noise in the background, it'll just be him watching YouTube. Sorry.
Okay, so let me. Okay, bear with me because my computer doesn't like when I change my slides. Okay. Okay. Super. So here we go. This is you.
Thank you.
Okay.
I would just, in line with Peter said earlier, just elaborate a bit about the Danish health system and our role in this, and then I will go back to the background for specialty planning and the foundation it lies for the work with ERNs in Denmark, and what we've done so far in regards of communication from the Danish Health Authority about the ERNs. Next slide, please. As Pierre mentioned, Denmark is a fairly small country with about 5.6 million people, and we have a high spending on healthcare and a high number of doctors and nurses compared to many other countries. Next slide, please. The Danish Health Authority is situated in Copenhagen, actually in an old building that used to be part of the docks. So it was used to be a lot of dock members that actually were in the buildings that we now try to promote healthy living. And I think they drank and smoked a bit more than we do now in the Danish Health Authority. We are about 200 employees, and we're a part of the Ministry of Health. And we are regulated by the law, by the parliament called Sundhedsloven. And our finest mission is to promote health for all. That's our motto, which is also what you see in the little icon in the corner. It actually just symbolizes health plus all. The circle is symboling all people. Well, that's enough about us. Next slide. The Danish hospital system actually goes way back. We started being a payment pay-per-fee system actually, and that evolved into a taxation system, which basically covers 97% of all healthcare. We had a lot of hospitals in Denmark going back. We had around 200 hospitals, but it was shown that we needed more centralized planning, and over time we had some structural reforms of the municipalities and later the regions. So we now have 5 regions and 98 municipalities, which primarily take care of the primary care, while the hospital care is located in the regions. Next slide, please. And as Pierre mentioned also earlier, the regions own the hospitals, and they have some contracts with the private operators and also the GPs, and they have a regional planning system, while our job is primarily to make national policies and the general planning, and also setting the overall framework for the whole healthcare system. Next slide, please. And we have 21 hospitals with emergency care, and then Rigshospitalet, which is Pier's hospital. And we divided it into 98 different medical specialties, and we have increased the centralization through specialty planning during the last 10 years. Next slide, please. And the legal foundation for this is actually in the law that the Danish Health Authority can decide which hospital shall handle what kind of patients. And we, as in Sweden, we also do a follow-up yearly on different indicators, and also they need to tell us in writing if they don't follow the specialty planning, and we have another authority that follows up that the doctors actually also follow this specialty planning. But as Pierre mentioned, the ERN isn't a foundation of this legal health act, and we might actually see some kind of revision of this in the coming years, because we're also planning on updating our whole specialty planning, because we also want to have a better flow for the patients from the GPs into the highly specialized care, which is one of the things that we're actually working on. Next slide, please. We have a guiding principle, which I actually also think is the guiding principle for ERN, and that is actually that practice makes perfect. That is actually one of the things that we try to have as a guiding line in our work with the specialty planning, and that means that we want to make sure that we have a uniform and a high quality treatment across the country. And we also have a high degree of cooperation between the different centers of expertise. And also in our specialty planning, we actually also don't just look at the function, but also at the supporting function. So if you are a department doing liver surgery, you also need to have a setup for the anesthesia, and all the other different parts of the hospital also need to work together and have those functions. So it's not only about the actual function, but the whole hospital around the function. And in a way, it's also what we see with the ERNs. It's not only about the function, but it's about the whole system surrounding each patient in the ERN. Next slide, please. The structure is that the ERNs are primarily the highly specialized treatment, or the regionalized specialized treatment, and we have some treatment that we actually don't perform in Denmark, and we have a special system to refer those to the respective countries. It's a challenge for us to translate these different functions in the ERN into our specialized system, because it's not one-to-one, and we haven't really found the perfect setup for the ERN so far. But our current line is that we try to say that you need to at least have these different kind of functions in these different ERNs to have an approval from us to participate in the ERNs. But it's a fine line, because we also have some small hospitals that have functions that are very relevant for ERNs, and we don't want to have a culture that actually excludes these centers. But that's where this whole idea about national collaboration also comes in, because if we involve all the university hospitals, we will get this referral pathway more controlled also in the hospitals that aren't participating in all the ERNs, as PS Hospital almost is. Next slide, please. In regards to communication, we've actually made a sub-page on our webpage, which is in Danish, where we tell about the different networks, and there is a little film which were provided by the ERNs, and it isn't that updated the last year, but that's mainly due to COVID. But there is actually, if you search for ERN and are situated in Denmark, it will be one of the top hits, this page. Next slide, please. And we also have a current list of all memberships, and also the contact person of the network in the hospital, which were written down when the hospitals applied for the function. So we have somewhere where both patients, doctors, and nurses can go and see, well, this ERN is actually situated here, and I can call that person or call that department and find out what to do next. Right now we have 17 full members and 31 affiliated partners. And we are, as Pierre mentioned, waiting on the decision on the full memberships before we can progress, because all the affiliated partners will, due to the current legislation of the ERN, be terminated if there is a full membership in the respective country. And we see this as a bit of a problem going forward, but we hope that the majority of our affiliated partners will be converted into full memberships. Next slide, please. We also have a national strategy for rare diseases, which was in its current form made in 2014. And we are doing evaluations. The next one is due this December. And we actually have a whole chapter dedicated solely to the ERNs and the progression of the work related to ERN and the Danish involvement in ERNs. And we also had some new funding this year to actually develop a generic referral program for rare diseases. So we will try to describe how the road into the healthcare system in Denmark shall be for rare diseases. It's a really hard task, but we are hoping that we'll succeed. We're definitely in the hard part right now, but hopefully it will be a good strategy when we finish this year. Next slide. For the future, I think we'll as a national authority will do more engagements into the ERN as the structure matures, when we have a full vision of these new applications for memberships. We also want to do some webinars for broader communications about the ERNs, and there's actually a few of the university hospitals that's done their own webinars to enhance the knowledge of the ERNs, but we want to strengthen that work in the coming years. and we are also in the talks about doing a national conference for all the members in Denmark to try to enhance good practices and knowledge across the different networks. And we're also considering doing a kind of survey to get more feedback on the national learnings by the ERNs. But a lot of this work has unfortunately stalled a bit because of the current pandemic. But we hope that we're at the good end of it, and we'll hopefully try to engage some of these issues during the later part of this year. Next slide. Yes, I think that was that.
Thank you for that, Søren. Thanks for the presentation. So now we have Elena Dolphus. Welcome, good to see you. And she's going to cover the national networks, the Filière Maladies Rares in France. Hélène, do you want me to share the slides, or you want them? You want to share them yourself?
As you wish. I can. I just have a try on sharing, but I'm not sure I can do it. In fact, I don't find it on the. So maybe you have to share it to share them. You will have the own version. It's okay.
Okay.
You have them, or if not, I can share them.
Yeah, I have them. Hold on.
Wait, I can.
Oh, you can? Super.
Just no, it's you. It's not me. I'm not authorized to do it.
Okay, no worries.
You so. Wait, unless this one. No, it's you.
So here you are.
Thank you. Thank you very much. No, so thank you for the opportunity to share with you. Do you hear me well? It's okay. Yeah, to share the French experience and also our more focused experience with sensorial rare diseases. So I just give you a brief overview of our history and how finally we may be a little bit on the opposite side of other countries and the way where we have approached ERNs. So as you know, maybe rare disease in France is often considered as a model. Because it's true, we have a long-standing history of rare disease plans and rare disease national initiatives since 2000, I would say 2004 actually, where there has been a lot of national initiatives that have been carried by the French Ministry of Health and also the French Ministry of Research. So this is a long-standing history where finally the founding stone of the whole system is the creation of rare disease reference centers. And at the time, the rare disease reference centers, they were legally recognized because they had they produce medical expertise as well as research expertise. So we had files to fill in to prove that we had a specific expertise in the field of rare diseases, and we also were and the patient organization were also had to be very supportive. And I would just open a parenthesis here just to say that it is thanks to the rare disease organization that there has been such empowerment of rare diseases in the general picture of healthcare in France since 2004 and even before. So the rare disease centers, I will come back to this in a second, but are officially recognized in our administrative system, and with the journal, they are officially advertised at the national level. So next slide. Yeah, so here is the summary of the different rare diseases and how it has impacted the creation of the rare disease reference centers, again, the founding stone of the whole system. During the first national plan between 2005 and 2017, and the first two national plans, I should say, there were 131 reference centers that were launched, and also additional centers that are called competent centers, and we will see the difference in a minute. They are much more of them on the territory, and you will understand in a minute. And if we summarize, in 2020, today on the French territory, there are 363 reference centers, and there are different levels of reference centers, some of which who are in charge of coordination, a third of them, and the other 2/3 that are more executive in their missions. And there are 1,800 competent centers. So it's a huge ecosystem at the time being, with these different types of reference centers. Next slide. So the role of the reference center, just to define well what they are supposed to do. They produce, first of all, a patient high-level care. So they have a mission of healthcare, and they are really specialized in the specific field. But they also have to provide teaching activities, training activities, and research activities. So at the time being, only reference centers receive funding from the French Ministry of Health, but not the competence centers. And the funding is for the missions of teaching, training, and research, and not for care. So for the competence center, it's different, because they are really, their mission is to ensure a geographic coverage. So they come on the follow-up and on the general organization of the care pathway of the patient closer to their home than usually the reference center. The next slide. So the patient pathway, it's very broad what I'm saying here, is because we cover, the system cover all the rare diseases, but usually it's either the general practitioner or a specialist that would refer the patient to a rare disease center, usually located in a university hospital. And where the general care will be organized, and if needed, we will connect the patient with a competent center closer from their home in their region of France. This is a very simplistic way of seeing the care pathway, because we could adapt this to each field of disease. But just to put the general organization in perspective for the general discussion later on. And if you wish to have more information, we give you here useful links, and I hope the PowerPoint will be accessible. Next slide. So in fact, where we're going to connect now with ERNs, because I thought it was important you would understand the basic of the French model, if I can say this way, for rare diseases. The second national plan, in fact, one of the main missions was to create what we call les filières de santé, maladies rares, which are in fact rare disease networks at the level of the French country, in France. So the missions of these networks is to facilitate the guidance of the patient in the national health system, to collect health data, to disseminate good practices, to coordinate research, teaching, and training action, and to ensure international influence and connection, especially with Europe. So these filières, these networks, have been created, in fact, to federate the centers of reference in a more structured system that would be more efficient at the level of the country. So next slide. So you have here what was organized during the second French National Plan since 2014, which are the 23 rare disease networks, what we call the filières, where you can find here the list of the different fields that are covered with these networks. So you see me coming for the next steps with the ERNs, for instance, for the network I'm in charge of, which is called Sans-Gêne. This network covers rare sensory diseases, meaning eye diseases, but also deafness. So all the sensorial, and you will see there are differences between the filière and the French networks and the ERNs, but not too many. And you can see that there has probably been some influence looking at the French system. So next slide. So the networks have become, and I think this is very interesting, but it has taken time. Of course, it was not directly in the first week that we managed to do this. We are now in our second round of networks. So we really are a central actor of the French rare diseases action. We really coordinate the actions of the center of references. We are highly involved with them, but we also coordinate, for instance, the organization of the laboratory testing, for instance, for genomic testing. We are very involved with the research activities. Also, we are supposed to be implied with the medical social structures, with of course with the patient groups, etc. So we have gained during time really a central position that is actually well acknowledged by the Ministry of Health, that actually leans very much on us for the follow-up of the third national plan for rare diseases that is currently ongoing. So next slide. I think this is about the funding. So there is a direct funding from the French Ministry of Health to the networks, so to the 23 networks, but also direct funding to the centers of reference. So it's separate fundings that do not depend one of the other. Next slide. But it comes from the same source, which is the French Ministry of Health. So of course you're all aware about the creation of the ERNs that took place in 2017. So are they strictly identical to the French network? No, not immediately and not automatically. And for instance, for our network, finally, we have the ERNI that covers the ophthalmic conditions, and the deafness conditions are covered by ERN crânio. For instance, this is a difference. So next slide. So just also to put things in perspective, in the ERN coordinations, there are 8 coordinators that are actually French. So you have them listed here, and among them you have 3 coordinators who are also coordinators of networks. For instance, so this is my personal experience, but knowing that the organization of the national filière and the ERNs in the French system anyhow are very tightly are very tightly, there is a liaison that is very tight. Next, excuse me for so today we are in the third, I have been speaking English all the day because we had our ERN meeting, so I'm mixing my words, so excuse me for this. So today we are in France in the third national plan, and there is really, as I told you, a very central activity of the filière, and we are of the networks in the organization of different actions, and especially the EU actions. So this is very important. And this national third plan is really aiming that we provide accurate diagnosis to rare disease patients in 1 year. So there is a high level of expectation from our ministry to reduce the odyssey of the patients, and a lot of specific actions have been done in this perspective at the level of France. Also at the level of France, there is the French National Plan for genomic medicine, where we are also, as a filière, very much involved. So at the for concerning ERNs, and I just put these topics because it may come back in the discussion later on, just to situate the position of France and the EU initiatives. We really are asked to keep in line with the ERNs. So we have actually some funding support from the Ministry of Health for the coordination of ERNs. So the 8 coordinators receive a little bit more funding to help them in the organization of the coordination of the ERN. And also there is a new aspect, and I think this is very interesting. So if we have centers of reference that participate to CPMS activities, this is going to be actually recorded in our annual record, and this is going to be recognized by the Ministry of Health for the funding of the centers of reference. So I think this is very important because this is a question that is coming up regularly on how centers in Europe are acknowledged for the time they are spending on, for instance, activities of ERNs such as CPMS. And also in France, they have the Ministry of Health has launched a specific EU group to assist the French coordinators in their missions for ERNs, but also, as you know, we have a representative at the board of member states. So there is a lot of information circulating between the French coordinators on what is happening at the level of the ERNs and how we can do our actions even better. So next slide. I'm too long probably. So here are how the sort of mirror activities between the French networks, the filières, and the ERNs. We see that we have some parallel activities that are requested either by Europe or by the French Ministry of Health, like guidelines. I will go quite quickly, like data management of patients, like the French National Bank for Rare Diseases data set, and the ERN registries. We have worked on Thesaurus in France, but also on ontology, the same thing we have been doing at the level of ERN. We have also missions for education and training, genetic testing challenges, and research and clinical trials challenging. So just to show you that we have missions that are parallel, and this has an impact, for instance, for my network in France and for the ERN networks, because we share common human resources, and this is very good for the operational on the daily operational aspects of the French network and the European network. So we share, for instance, people on the Sangen network and the ERNI. Next slide. So this is the sort of snapshot of the situation in France, because and the ERN, the members of the ERN are all members, of course, of our national French network. So applying for the ERN in 2016 was very easy for the French part, anyhow, because we already had all the data, and all this was quite easy. And the centralized aspect was, in fact, here added value for us. For once, next slide. So that's just what I just told you. So the first application for ERNI, for instance, was really quite integrated for the French aspect. It went really very smoothly. Next, of course, for the others, it was more complex. And here we can see again how we share the objectives of ERNI and at the French level, and how we try to mutualize our expertise and our actions to really enable work that can be done more easily from one side and the other. For instance, for the guideline work, we try to utilize our expertise to try in the two ways, at the European and the national level, so we can profit from this specific position. Next slide. So this is the example, sorry, of our specific field of action. Of course, for the other ERNs, it may be slightly different. I will, next slide, please. I think this one is too much. And I also will pass this one because I've been speaking too much, I think. Just a specific point on the French genomic plan. Just to tell you that the French network, the Filière de Santé Maladies Rares, has had a very specific action to implement how the patients can profit from the whole genome test the National Plan France Médecine Génomique is providing. So we really, all the filières in France, not only ours, of course, have had a central action in prescribing the whole genome tests for the patients, for the rare disease patients. So this is an example where we have had a central action to promote activities to reduce the odyssey of patients. Next slide. And this is, we have common meetings at the French national level where we, and this is, I have soon finished, but we use tools to, for instance, to prescribe or our genomic testing. So this is where we get to the limits of each systems. I will finish on this because everything I have just been saying you would maybe imagine that we are in a fantastic world and everything is easy and we really can do everything so smoothly. But in fact, no. We can see that we are not able to use the CPMS at the national level. And that's where we start to see the limitations of having very strict, having very developed national systems where we had, in fact, freedom to use different systems to share data from patients and, for instance, for the prescription of the patients. And we had choices to use some specific systems. So we choose one of those. But for instance, CPMS it was not possible. I tried desperately to say that we have a European system that could be used and we could try and implement it directly at the national system, but this was not possible. So next slide, I think it's my last slide. We see that adding an extra new system is something that is difficult, for instance, for the prescription of genetic testing, although we try to do it. So yeah, I just wanted to, for the general discussion, to show you the forces and also some difficulties we can have in having an extremely well organized rare disease system for a very long time in our country. But also there are added values, but also we can see that there are difficulties in connecting directly with different European systems such as the CPMS. I hope it was not too complex to understand. I'm ready for any questions, and
thanks for that.
With this French example, sorry.
Thanks for that. I knew that you had your annual meeting today, so double thanks for accepting to be with us today, Elena.
Yeah, it's a strange transition for me actually, but
I can understand that. Concha, do we have any questions from the audience?
So I've monitored the chat during Søren's and Helene's presentations. Thank you for those interesting contributions. And there were no questions, so it seemed to be quite clear. Some comments, interesting insights and good practical examples, but no questions in the chat. Maybe people want to speak up or raise their, and no raised hands so far, but maybe Matt has a raised hand.
So I love, Helena, I love that your national networking, you know, we can see how over 10 years this has developed and matured and how it's become integrated, and we need that time. And really for the ERNs, it's a similar journey we're going on. And the importance of those collaborative competence centres seems to be the key around really making, you know, the filières not be an island of expertise, but they're connected to the national systems. So I just wanted to ask really Per and Søren, in terms of the Danish system, you're looking to look at national coordination. There's a will there? Is there the IT system or, you know, technology to enable that to happen? Do all your hospitals speak the same language, as it were? Or is it the same difficulties will come up?
Well, in Denmark right now, there is 3 different systems. 2 regions have the same system, but it's not that easy. So we have kind of the same, but we have some other platforms that are actually the same. We have the same system for X-ray imaging now, so it's easier. It's not perfect, but it's getting better. But I think Per might supplement that part a bit.
We have another national kind of electronic patient record where we're able to, if we need to get healthcare information about patients coming from other parts of Denmark, if they are have been in a trauma or something like that. So we are able to get at all hospitals in Denmark information about what's their usual medication and what's their health condition, which kind of operations have they been through, and so on. But aside from that, that's exactly as Søren is saying.
If I may, if you think about referring a patient, so Pierre was suggesting that what he thought could be the way was to have the highly specialized centers as being the ones entitled to refer a case to an ERN. Considering all these technological aspects, meaning that someone needs to upload the information of the patient in a system, that it's an external system from the ones that you're using. Also, considering that there has to be also another system, if you want, on top of that is managing the process, so that all the actors are kind of at least know where the process is and where the case is, and if there are any bottlenecks that need to be managed, that this is managed. So my question would be for the three of you, do you think that regardless of whether it's the highly specialized centers, the ones that are going to be able to refer a case, or if it's going to be secondary hospitals also. So regardless where the referral takes place, the referral to an ERN, would it make sense to have somehow a central function that would support the clinicians in actually making that referral? So once a clinician has identified the need for a referral, having a central function, if you want, maybe in the Ministry of Health or maybe in the Danish Health Authority, someone there that manages all the referrals into the different 24 ERNs. Would that, how do you think that could work? This is for the three of you, the question.
If I can start, I'll say, I think we have a well-functioning system in Denmark where we're referring patients to the highest level of competence in Denmark. And I think we should use our own national competences before we go abroad and ask for super expert help in an ERN. So I think the right way is to use the referral pathway we have, which we know are functioning. And then when we reach the top of the Danish system and we need more help, then we go into the ERN. But I don't know what Søren will say, but that's the way I'm thinking.
I agree with Per on that point. We also have what we call the Leon system, that we try to solve the case on the lowest possible place, also to ensure that the patient doesn't travel too much around the healthcare system. So it works both ways, because if we refer too many to the European system, it will also be a very long way for the patient.
But I was referring more to offering a support to the clinicians that are referring, a support in terms of managing the administrative process that referral would entail. So I understand that you want to exhaust all the national resources. Once that has happened, then you think it will be up to each clinician to take on, it would be his or her responsibility to take all the steps, administrative steps that are needed so that the patient gets referred? Or do you think that it would make sense to have some kind of support centrally managed for all Danish clinicians that want to refer a patient to an ERN?
I think that's a very good question, and I don't think that we have to have a central organization in Denmark for it, but I think we need a kind of central organization in each of our university hospitals or highly specialized hospitals. We are organizing an ERN network at our hospital just in order to have good administrative help handling the bureaucratic or the practical issues about the ERN collaboration, so that the clinician should focus on the patient and their professional collaboration with their colleagues in an ERN.
That's very good to alleviate the bureaucratic pressure on the MDs. Congratulations. That's excellent. I would agree on the fact that you have to exploit, all the resources you have at the national level and go to the center of reference. For us, it would be the competence center and the center of reference. And also, I would like to stress we function a lot also on common meetings where we discuss about the cases, and there we take a collegial decision whether this case will go to the ERN or not. More than a centralized, I don't know if you intend to have a automatic referral system, but I think we still need to have the expertise of collegial the collegiality of the experts, and to see when we decide to refer on the ERN level more than individual initiative. It can be, of course, if the expert is the top level and he believes or she that nobody can help, because indeed we should use at first the national resources, because if not, as you were mentioning, the ERN will be flooded with I mean, cases that can be resolved at the national level. So this should not happen. The cases for the ERNs should be at the level of the nation, and we know there are different levels in Europe, that you have used all the resources, and then you need to have really cross-border expertise.
Very good. Elena, one question to follow up on this. When you say that you discuss among experts, that discussion takes place with the experts of the filière or within your own center?
Well, we have at the levels of the center first, and then at the level of the filière. But it can be also at the level of the center, where you can take the decision to address directly at the ERN, because you know that anyhow I mean, it can be both, but logically it should be at the level of the filière. But of course, we have not enough resources. Also, to be honest, we have not enough MD resources to deal with the flow of patients. So in theory, it should be that is what we presented to the Ministry of Health. We have different levels, but of course we are not enough MDs. So sometimes it goes directly from the center of reference to the ERN, but usually it's exceptional cases. So we know that anyhow it would be a discussion at the level of the filière, but we can have this level of discussion too.
Yeah. Thanks. Matt, do you have another question?
I've got loads. So to peer really, I get, so, you know, you want to, let's say for metabolic, connect your metabolic experts nationally, and the referral to, if needed, first of all, sweat the competency within Denmark before then referring to an ERN. I get that. What if you don't have an expert recognized and therefore there's not the connection with the ERN? How does that pathway work? So for, let's say you've got someone for pulmonary hypertension in the ERN lung network, but you've got someone needing advice for idiopathic lung disease, or how does that work? Because you're not going to get the pulmonary lead to act as a coordinator, will you?
I don't know how that'll end, but you're quite right. That's a problem, and I think that's one of the important things we have to deal with in our national network. I suppose that Denmark will be member of almost all ERNs, and then we'll handle it in that way, which we have discussed. If we have situations where we will not become members of ERNs, I suppose we will look to our good neighbors among the Nordic countries and try to collaborate with Sweden or Norway or Finland. I think that's the way we would go, because I think we need to collaborate closely with other hospitals which have a quite similar system to ours, and well, there's a strong connection between the Nordic countries, so that would be a natural way to go, I think.
And just to follow up really probably to Søren and Per Henrik, in terms of, you know, we look at the ERNs as being a collaboration of the clinicians, the experts, but really we need collaboration between ministries of health like yours, and in terms of planning. And so Pia was mentioning about the collaboration which you have in the Nordic countries. Maybe you could expand a bit on that, because you said that some of your services in Denmark aren't provided in Denmark. And so how do you collaborate, and where did that come, how did that develop between countries, so you could organize services cross-border, for, let's say, for the Nordic region?
Actually, we do have a Nordic network for rare diseases. So a part of the collaboration around rare diseases actually also try to flow that way. And there's also some very specific collaborations between hospitals in Sweden and other countries. So yeah, I think Pia might elaborate a bit more about that thing.
I think we have some examples of very, very well functioning collaboration. For instance, in Denmark, we're not treating people or children born without the outer ear. They are referred to Malmö in Sweden and treated there. And we have a Nordic collaboration concerning burn casualties if we get too many, so it's difficult to handle them in each of our countries. So we have systems where we're able to refer patients between the Nordic countries, and as I see it, it's very well functioning. But I don't know what Per Henrik is saying.
I agree with that. We have the same picture, and there is also some forms of collaboration on the sort of national authority level, as Søren mentioned. In this one group with respect to rare diseases, and another group with respect to highly specialized care, and they are both organized under the to help me with the English word, under the Council of Nordic Ministries, which is a collaboration between Nordic countries that goes really a long way back. So, I mean, it does not cover all sorts of disease areas, but there certainly exists on the ministry level, on the agency level, and then we have specific collaboration in certain disease areas. And I think, coming back to our system, when we have a few of our national specialty services with only one provider, because volume is small and the expertise is rare, then it's really important to have contingency plans, so that if something happens, could be outbreak of multi-resistant bacteria, or could be that they, for some reason, lose critical competencies, then we should have contracts in place so that we can refer patients to other countries. And as Per mentioned, it is the first step usually is looking at other northern countries. Then there are, of course, other examples where we have to go to other European centers for certain very rare or very special treatments. But I totally agree the picture.
I think that shared planning and strategic planning is really important, and I think that's what we're missing probably in lots of other parts of Europe. In France, I think Helena probably has a big enough population size probably for your regions to do that. But you know, for lots of the smaller member states in the East, actually having that planning cross-border would be really important. And I think what you're demonstrating in the Nordic collaboration is brilliant. It sounds really great.
I have a suggestion for Søren. So you were mentioning an ERN conference. Could be a Nordic conference rather than a Danish one. So that would really, you know, you could start building that kind of collaboration already. through that conference. That will be brilliant, because I think that you're right, Matt. Going forward for the Nordic countries, it will be very good to come together because of the size.
Actually, that has already happened a few years ago, and we actually talked about doing it again in the rare diseases. But there's, due to COVID, it actually haven't happened. But we hope that the Finnish will actually do it in the next year. But we're also working on that. But that's more the whole rare disease area that covers multiple sectors also. We would like to hold a specific conference for the ERN part of it, because it's part of a bigger ecosystem that also involve social healthcare and education.
Thanks. And I have a question for Elena, because for me it's very interesting, coming from your background with the filière, etc., and where everything is now very well organized. So you have the competence centers to follow up on whatever advice has been given, and everything is kind of nicely tied together now. And now you have the ERNs coming into the picture, and Pierre was mentioning that for Danish clinicians, they might not all be aware that this new structure exists. So I was wondering two things. First, do you think that in France, ERNs are well known by the experts that are not part of the networks? And the second thing is, how do you see, or do you think that it will be necessary to do any formal changes to the legislation in order to integrate the ERNs? Or do you think that that can happen without really any formal modification of the legislation, and it just can, you can organize it just because you have already a very good national and network structure?
You mean the national legislation?
Yes.
Yeah.
Yes.
Well, to answer this part, I think it's, it's very well recognized, the ERN position at the national level, at the Ministry of Health, etc. They are, I think they are very aware of what is going on. Now on the field, in the centers of competence, and do all the center of reference are fully aware about the existence of ERNs? Maybe not all. I think there would be some communication to do, for sure. Now in our field, I speak for us in ophthalmology. I think we are quite small, and everybody knows about this resource, because the centers of reference are all partners of ERN, so it's quite smooth. Now in other sectors, in other fields, it's maybe not as easy as that. And I've heard, our ERNs, what is the purpose of ERNs? Finally, we have everything. We suffice to ourselves. I have heard that in other fields. I will not mention which ones, but this is another layer of administrative and bureaucratic burden. What is the use of ERNs? Because finally, in a system like in France, people think that it's enough, and they do not need to go to European level. This is not the case. I think in rare diseases, it's never enough, and it's always very complex, and you always have ultra rare situations, and you can be the world expert on one disease. You always have challenges. And these are the ones we want to bring at the European level, for instance, at the level of France. And again, if you compare with other countries where it's, for instance, in Eastern Europe, or, I think there is a real added value to share expertise. So this is something that where in the French centers of reference, they should more, sometimes maybe they should be more aware of the solidarity that is expected. but it's not only in France. I have seen that with other countries that are members of our ERN that think that finally, what is the need of to have an ERN, because they are a big country, a big surface, and they have a lot of expertise, a lot of university hospitals. So finally, why do we need this extra layer? And this is where we should maybe communicate a little bit better, you know, because I mean, because they do not realize what it can actually change for some other countries. This is important.
Yeah, they should have listened to Pierre. Yeah, I mean, he was explaining very clearly in his intervention how he thinks is beneficial to be part of the ERN. One of the things that Matt always says, and he repeats it to death, is that in order to keep up with the state of the art, you need to be sharing, on a continuous basis, and you need to be exchanging expertise on a continuous basis. Otherwise, you lose.
It's sure. I mean, in rare diseases, in the clinical part, but in research part, I mean, you cannot do that as a isolated. It has to be at international level. It has to be at European level. It's for sure.
I want to just add, in the UK, we had a poor performing children's heart hospital, and it got very bad press. And it wasn't because it wasn't very good. It was because the whole of the other hospitals had got better, and they just weren't connected. So they weren't sharing learning. And I think the risk is, if you're not involved in that, a learning system on a clinical basis, on a specialty basis, then you can fall behind. And actually the benefit I've seen is when you have the international leads for a condition talking to each other, discussing management and diagnosis, they learn from each other. And I think that you can't, you don't see that, but outside an ERN, but when you hear them discussing it, you can see how massively they're benefiting from it. And these are the world leaders. So I had a question for you, Elena, about in the lifespan of the French network developing and maturing, what was the single most important point or action which moved this good idea into being a mainstream part of the French health system?
I think probably, I mean, in practice, it depends at what level. When we started, now a few years ago, I would say it helped people really to exchange exactly what we were just saying now at the level of Europe, and it really it put down all the walls that were between hospitals, traditional things, and finally people were able to speak to each other. And I think this was very good. This was very positive, because, and thanks also to the patient associations, there was really a dialogue that maybe was not there before, because you can work in silos. It's exactly what we were saying before. You can work in silos, and if nobody tells you something outside, there's nobody outside. So this was something, I think, at the beginning of the network that was really very important, that there were exchanges between the professional, the different hospitals. In some big cities, the hospitals can be in competition and etc. So these borders really fell, and that was something that was very, very important. And now today, what I would say, what is really important is, for instance, for the French genomic plan, as the borders have fallen, this really eases the implementation of a new system of prescription for genetic testing. So I would say that we are operational. We have become operational to get access to better testing to our patients. And this would be one of, I think, the breakthroughs I've seen in the last year. So yeah, there's at the beginning and now. And also, I would say in between, for the ERN, That was really in between these two timelines. It was so easy for the French to team up. That was really pretty good. And I saw the difficulties in the other countries where there was maybe less organized and less, we were always complaining before about the bureaucracy and the centralized bureaucracy in France and etc. But finally there it was helpful. It was really helpful because the applications, it was not no effort, but it was really easy to find all the informations we needed. It was ready. In other countries, I saw it was much more difficult, and it was much more tedious for some applicants. And even in some countries, I saw in the first round in 2016, some very good centers that just didn't get on because they couldn't assume the bureaucracy and the administrative load of information that was needed. And it was very sad because it was very good experts, but they stepped out because of that.
So if there are no further questions from the audience.
Yes, there was one question in regards to if any one of you is aware of plans of other smaller countries building networks across the region. I mean, like the Scandinavian example or the Nordic example.
So, and Pierre, when you are in the Board of Member States meetings and you exchange with your colleagues, is there any, when you talk about national networks, or if you've discussed about them or the collaboration at national level, is there any small country that has or has plans to, maybe the Estonians, Lithuania?
Yeah, Baltic Sea, I would say they're very organized.
Yeah, I think the Baltic countries might team up also at some point on this. I see a question coming from Bernd. Lenya, can you read that, please?
Yes, for multi-organ and multi-system diseases like sarcoidosis, the cross-ERN expert collaboration on specific cases of patients needing multidisciplinary and even multi-model expertise is nowadays not in the focus for future development of the ERNs. So it's a comment.
It's yeah, I think we are very much aware of the need of inter-ERN activities. And we are starting to have such activities, for instance, guidelines on syndromes and some research activities. But it's true, but it's awaited from the Commission, I think, that we develop this type of activities. And for sure, you're perfectly right. I mean, some diseases, they are covered by different ERNs. And hopefully in the registries also, we will be able to pinpoint these situations.
Actually, last year there was an ongoing work in the ERNs to cover these links between the different ERNs. So that work is still ongoing, but it is a challenge. It's a challenge in every healthcare system, covering diseases that go beyond the different specialties. So it's a known issue that we just need to work with.
Yeah, absolutely.
Hopefully there will be some funding to continue that work, which I'm sure, I mean, that work is really important, to be honest with you, because, let me wrap up if there are no further questions. One of the things that Søren presented, which might look very obvious for everyone, is that they have this list of people, actually names, right, of people that you can contact that are kind of representatives in the different ERNs at national level. For me, that thing that looks really minor is massive, because get lots of requests from patients at the national level asking, okay, what do you know, who can I talk to? What can I do? Having that at national level in your local language, I need to you know, acknowledge and recognize that it's of great value, even if that's really not so difficult to do. So if you can share that with your colleagues at the Board of Member States, so that, you know, it's a small step, but it's really already something. The other thing that I've noted is that you are going to develop this generic care pathway for rare disease patients, and that you're going to try and include the ERNs. That will be massive also. So I think that Denmark is really in the good kind of path, even though there's lots of work to be done. And on France and the filia, what I think that my takeaway is this, what Elena was referring to, that the culture of competition turned to be a culture of collaboration, and that is something that we would really like to see in the ERNs also happening, even if it will still take some time. And again, I think that France can lead with, you know, not. It's just that the French system is so well organized at this moment that, and they're going to be, of course, there's going to be the French presidency. There is this also this EU group that you have, Elena. So I think that you can lead a lot in, you know, the following next few years into how this integration can look like and how to articulate it, even if the health systems are different, what have you. But we know that, but I think that France has a lot to share. And just to thank you again for being with us this afternoon and for sharing your views. We have the recording of this session, and we will share it with the participants, and we might also post it in our YouTube channel. And I hope that we can maybe meet in 1 year time and be you know, discussing about you know, how things have evolved and how things have progressed. I really hope to see some changes next year in terms of integration and referral pathways. Thank you, everyone. Thank you, Matt, for organizing this 2 webinars. They were great. And thank you to all our speakers, to Elena and Concha for being there also. Handling the back office. Have a nice evening and take good care. Bye.
Bye.
Thank you. Bye.